One of the things that I've learned is maybe as South Africa, we really don't give ourselves enough credit for the advancement we've made, not only in Africa, SADC, but globally. I was part of I joined the Management Sciences for Health fora where they were sharing lessons, and a lot of the issues like health technology assessment, issues of antimicrobial resistance, antimicrobial stewardship, those are things that already as a country we have really advanced with and implemented and institutionalized. And for me, for example, when we talk about selection, we use health technology assessments to make those decisions as through NEMLEC in terms of what medicines do we need to provide. In terms of distribution procurement, we use a national system in terms of looking at pooled procurement, for example, so that we benefit from economies of scale where we are able to negotiate contract prices. And as a country, we've managed to reduce cost of providing ARVs. As you know, that our country program is the biggest ARV program globally, even for that matter. And as a result, we were able to significantly reduce the cost of providing ARVs to our patients, or those people living with HIV and AIDS. And that is the selection procurement, where we are able to procure at a lesser cost due to our pool procurement processes. In terms of distribution, obviously, we've devolved the responsibilities or decentralize the responsibilities for distribution to the provinces, because then at least you're able to tailor make the distribution company or contracts based on what your own needs are. Remember, as a country, we have different geographical distances between the facilities, so we were able to also leverage on outsourcing or making sure that the companies actually, assist us in getting the medicines directly from the supplier, directly to the facility, without having to go through the medical stores at a provincial level. And that has improved our efficiencies in terms of getting medicines on time in the right quantities to the facilities that we service. In terms of legislation, our statutory council, which is the one I serve on, which is the South African Pharmacy Council, has really been in the forefront, where we even having some of the SADC countries, regulatory authorities coming and benchmarking with South Africa. We present at a national FIP, the Federation of Institutional Pharmacists, international pharmacists I meant, where the country is represented in terms of our advancement in research and development. And those are really, research and development that informs the decisions that we make. Evidence, as I indicated, it's an evidence-based approach. So the key lessons learned from there is that as much as there's globalization, we were able to leverage on the resources that we have to ensure that access is available to our facilities. We were also able, at a country level, to engage stakeholders. We have a lot of development partners that have assisted us, especially with COVID, where we were able to ensure that as a country, we don't run out of medicines. So the use of skills and resources from our development partners, those are partnerships that you want to make sure that they exist and you make use, and you don't get given the mandate. You as a country dictate what you need. As much as there'll be donor funding that comes that would, say we are funding this, but it's always important as a country where you have your key priority areas that you've identified as a country, so that your development partners assist you in attaining those goals. One of the other key lessons learned is the need to embrace technology, embrace artificial intelligence in making sure that there's access. I'll make an example. Through our development partners, Global Fund, we're able to procure automated dispensing teller machines making sure that we're able to decant our facilities and provide services closer to the patient. The patient doesn't always have to go back to the primary healthcare facility to get their chronic medicines. We're able to leverage public-private partnerships in making sure that access is available closer to the home. As a result, I think we're one of those countries, the 95-95 strategy. I think as a country, we are really doing well, where my province as the Free State were at 94 of those strategies. So for me, we've really done a lot, but with support from your development partners. So, and also embracing artificial intelligence, using technology to be able to advance the need to improve access and availability of these medical health products or medical consumables and medical devices. It's always important that you use research to help you find the answers to the questions that you need. So health as a system must always provide the research question to which research must find answers to. So it means you are then directing the research based on what your need is as a country. What information are you going to use in order to develop policies, for example? When we came up with a policy to use our differentiated models of care that I talked about, where we partner with public service or private sector, we were able to leverage on the systems that they already had in place to provide health services to the private sector. Now, public sector had to use those lessons learned in order to use, and that was a lot of research that went in, where we also took from other countries in SADC in Africa through our development partners, bringing those lessons learned in terms of how we go about implementing services to strengthen our health system, as I indicated, improving access. And how do you then manage at a facility level availability of medicines? How do you monitor even stockouts? So we had to use technology to implement technology that would assist us to have visibility across the whole value chain. When a facility in a clinic in rural areas is reporting a stockout, we'd be able to go and say, okay, what stockouts do you have? Are you currently experiencing, and what is the pipeline like? So right through the value chain, you are able to have data that has been inputted in these systems. There's a system that we use that's called the stock visibility system, where we are using handheld devices like your smartphones, where at a facility level, they capture the stock on hand that they have. And that information is even available at a national level, where the minister, when there are always stockouts, when the media say there are stockouts of ARVs, then he's able to go into the system and really say, okay, these facilities, they were reported stockouts, and these are the reasons for the stockouts, and this is what has been done from facility up to province, up to national, in order to address those stockout issues. So for me, building those systems and making sure that reporting data is available to inform us to make decisions. How do we know that a particular company is experiencing supply challenges? For example, we've had a lot of challenges with availability of some of the formulations of ARVs for our pediatric patients, and we got to find out where the supplier had to be open and honest and transparent in terms of what are the challenges they were experiencing as a supplier, so that we are also, as a service provider or as public service, better informed, so that we can make proper decisions. How do we ration stock between facilities? How do we redistribute stock amongst the facilities so there's equitable access and availability? So those are some of the capacity building processes that we did, where we strengthened our health systems with technology, making those devices available, where we improve access through partnerships with the private sector to make sure that the health system is able to respond to challenges with stockouts. And obviously, research and development, as we're using health technology assessment, where we embrace, for example, the advent of COVID that brought about the COVID vaccines, where we were able to save our healthcare professionals, and as a province, we're actually doing very well. But as a country, I think we're actually doing well in making sure that COVID vaccines are available to our facilities, even at primary health level. I would say political will and to invest in healthcare. I think as a country, we are doing well as compared to a lot of SADC regions in terms of GDP expenditure per capita on healthcare. And we've really, as a country, invested in making sure that we provide medicines, we have systems in place where we leverage and reduce cost of medicines through those systems that we have available. But also what is important is to make sure that I mentioned the issue of political will by our finance minister, the finance minister, the health minister, even the president, because we had a health summit where we were looking at what the issues are within the healthcare system. But also it was also to bring the private sector to account also, because it's always that the public sector, there's corruption and so on. But through that health summit, we're able to, and the health inquiry, we're also able to identify that there were challenges also within the private sector, that there was a lot of corruption. But for me, it's important that there's buy-in for us to implement universal health coverage. And through that, the South African model for implementing universal health coverage is our national health insurance. So it's important that all role players within the healthcare system buy in and understand why we need universal health care so that access is equitable. Remember, we come from a legacy of apartheid where access to healthcare services was not a reality for the majority of those who need access to health. So we need to have that political will, but also support from the private sector to take on this challenge, because I think as a country we are lagging behind. There are a number of countries who have implemented universal health coverage, and we do have lessons learned. We have a model that we believe is going to work, but what we need is people to understand how that model works, because people are thinking we'll have the national health system that is similar to the UK, but it's a totally different system. This is where we are contracting all private public service providers to help the country make sure that access to healthcare services is a reality. With COVID, one of the lessons we learned, remember I mentioned the issue of the differential models of care where we're partnering with the private sector to make sure access is not impeded. And we saw an increase in the number of patients who were enrolled in this program because they didn't have to collect medicines at the health facilities. As a result, we had people away from accessing healthcare services so that those health facilities are able to prioritize our COVID patients. What we also learned from that is we need to be decisive in terms of how we prepare the system for eventualities like those emergencies. As a province, we actually did very well where we were proactive. We formed committees, response committees at a provincial level that we then decentralized once there was capacity to lower levels where decisions were made. How are we going to procure PPE, for example? How do we make sure that oxygen is available? Where we capacitated our facilities and invested in those oxygen pipes within the facilities to make sure that if there's a need for a patient to receive oxygen, it is there, it's available, and making sure that the supply system for these commodities are also in place. Do we pull procurement leverage on economies of scales, but then once the numbers are died down, then we allow the facilities to do their own procurement. But once we started seeing the numbers, then we'd revert back, because there's nothing the system is health. The health system is adaptive, it's complex, and it's changing all the time. So it means you need as a system to also adapt and change all the time. You can't apply a one size fits all to the health system. One province might be different from another province. even there are those differences and nuances within the province, where depending on your geographical area, there are very rural areas. We have urban and suburban areas that we need to make sure that what we put in place works for those particular health facilities. So for us, those were lessons learned from COVID, and the fact that, as I indicated, partnerships with the private sector, they did the distribution of our vaccines even up to lower levels of care. It didn't have to come to the central depot before it reaches the facility. So we're able to make use of those efficiencies within the logistics system and distribution system to make sure that access is as efficient as possible. Obviously, the benefits are the systems that are already in place that we can leverage on. The drawbacks would be the cost. Sometimes the cost is exorbitant, and as public, we are not able to meet. But for me, what's important is once we have a single health system, then it would make it easier for government, for government to provide those services, at a lower cost, but also embracing machine learning, artificial intelligence, because I'm one of those proponents of artificial intelligence to make sure that services are provided at zero cost. I mean, we have smartphones, we have smart watches that can even assist in taking your basic vitals and having telemedicine happening, so that a person doesn't have to leave their home to access health services. As a health professional, you're able to provide services over, I mean, now we have Teams, we have Google Meet, we are able to talk, we have meetings, and there's nothing that says consultation can't happen. I can take my vitals and send them to you over the phone, and you are able to monitor and then provide an indication of what is happening, what's my status, and as a result prescribe. But sometimes regulations and legislation could be a barrier to having those kind of information, because we need to move with the times to say there's nothing wrong with a script or a prescription that is sent online, as long as you can validate that the script is valid. So for me, it's us as a country and as healthcare professionals embracing the advent of the fourth, fifth industrial revolution, and making sure that we leverage on those. Even decision making, as people who are involved with health technology assessment, can you imagine the literature review that you have to go through in order to come to a point where that this information or literature supports us using this particular technology in terms of advancing health. But you don't have to go and peruse volumes and volumes of literature. You can literally use artificial intelligence, machine learning to go through all the information that's available, give you a summary of what is available on the market, and help you make those kind of decisions. There's a lot of data, there's a lot of information available out there that can be consolidated for you to assist in making decisions. Absolutely. I used to lecture pharmacology, and my head of department at that particular time was into what we call pharmacogenetics. And this was looking at how your genes make, or your DNA can determine whether you're a fast metabolizer. When you're taking a medicine, how do we then tailor make and taper your treatment in order to make sure that if you are a fast metabolizer, then your doses are increased so that you reach, that therapeutic range that you need. So for me, it has always been, and it's quite exciting. There's a professor, a South African by origin, Ruben Pillay, that I follow also on LinkedIn, and he came. We had an opportunity and the privilege to have him present a workshop for us, where he was talking about artificial intelligence and providing healthcare at zero cost. Making sure that we tailor-make treatment based on the patient, so that we deal with issues of adverse drug events, toxicity, and so on. So for me, that really is very exciting, and I'm excited as a proponent of artificial intelligence in making sure that the need has become so much. Life expectancy has increased to 70s, 80s, and how many people do we then need to provide health services for? So if we're able to provide healthcare at zero cost, by all means, because our resources are really not infinite. We have finite resources. So we need to make sure that we leverage each and every sector that is available for us to use. Yes, sometimes there's, we have all these competing priorities because we know that the fiscal or the fiscus is shrinking. Um, Availability of resources is really a challenge. I mean, you look at a global level, the amount of donor money that is coming through to the countries, the restrictions in terms of what you can use for that donor money. So it leaves it to the country to look at how do we then provide healthcare services. And for me, the world, not only at a political level, but even from us as healthcare professionals, the space I work in is really regulated. We have regulations in terms of what's the price of the medicines that a pharmacist can sell. But in terms of provision of healthcare services by other cadres within the healthcare system, there really isn't any regulation. You can find an anesthetist charging a patient exorbitant, fees in terms of accessing health services, the exorbitant fees of our oncology drugs, So for me, once you have that national health insurance, you'll be able to, manage the cost of providing healthcare services. I think I've mentioned a number of them, how other countries like Rwanda has embraced the use of artificial intelligence and machine learning in providing the basic services. When a patient goes into a clinic, they could be seen by a robot. I can't remember the robot's name, taking the vitals. They made use of these during COVID. Use of robots and drones to deliver medicines to facilities, especially to those remote rural areas that are not accessible with our normal transport. So those are lessons learned as a country that I think we could take from other countries within the country, within the continent, and also at a global level. Other lessons learned, I think, is the issue that sometimes legislation could be a barrier to accessing health services, where as much as we want to deal with corruption, make sure that there's governance within our procurement systems, sometimes over-regulation can be a barrier, where now, I'll make an example. We have what we call the Audit Act. We have auditors, a sector that audits using our financial legislation or prescripts in terms of how do we procure. Sometimes these are not flexible. As I indicate, I always apply the 80-20 rule, the Pareto principle, to say 80% of the things we can do in a normal way. But there is that 20% of issues in the procurement process, for example, that needs us to look at alternatives or to do things differently. But then because now there's a lot of legislation around that, there's consequence management, there's, that makes it difficult for decision makers or accounting officers to make those difficult decisions, to say this decision is not within the prescript, but because a patient's life is at stake, I am going to make this decision. So it makes it difficult for accounting officers, chief executive officers, heads of departments to make those difficult decisions because they fear litigation, they fear being taken to prison, because those are issues that the Auditor General always raises. And sometimes you would not have an answer to say, yes, Auditor General, the procurement process and the prescript says I should have received 3 quotations, for example, if there is no contract for this particular item. But the people who are quoting are not providing are not meeting the specifications. And I know this particular person has the items that I need. I can't go directly to that person and request that person to provide services. I must go through laborious, extensive red tape in order to get the services of a particular person that I know provides quality services. So these are some of the legislative barriers to access, accessing commodities, accessing services, etc. So for me, we need to make sure that as much as we put governance structures, governance processes in place, they do not create barriers for healthcare professionals to be able to provide services.